Amenorrhoea is absence of menstruation. This can be physiological or pathological. Physiological can be primary or secondary. Primary is before puberty and secondary is during pregnancy and lactation and after menopause. Pathological can be concealed or real. Concealed is also known as cryptomenorrhea, which can be congenital in case of imperforate hymen or acquired in case of stenosis of cervix due to amputation or conization of cervix. And real amenorrhea can be either primary or secondary. Primary amenorrhea is when the girl has not menstruated till 16 years of age. There can be many causes including hypogonadotropic hypogonadism, when there is hypothalamic or pituitary dysfunction or CNS tumors like craniopharyngioma. Then there can be hypergonadotropic hypogonadism where there is primary ovarian failure. There can be chromosomal anomalies like Turner's syndrome, etc. Any girl that comes with primary amenorrhea, a thorough history and examination has to be done, including examination for secondary sexual characteristics and external and internal genitalia. Any girl with primary amenorrhea, if she has normal secondary sexual characteristics, the investigation we do is pelvic ultrasound or a diagnostic lab to see for the presence of uterus. If uterus is absent, then we do a karyotyping to see if there is 46XX or XY. If it is XX, it's suggestive of Mullerian agenesis, and XY suggests androgen insensitivity syndrome. If the uterus is present, then we rule out outflow tract abnormalities. If the uterus anatomy is normal, then we do hormonal assays for FSH, LH, TSH and prolactin. If they are normal, it suggests that the cause is physiological. If FSH, LH is elevated, it suggests ovarian failure. If TSH is abnormal, it suggests a thyroid dysfunction. And if prolactin is elevated, it suggests a prolactinoma. If the girl doesn't have the secondary sexual characteristics, then we look at the height, if it's normal or short. In both cases, we do FSH and LH assays. If the FSH LH levels are low, then it suggests a hypothalamic or pituitary dysfunction or a CNS tumor like craniopharyngioma. And if the levels are high, then karyotyping has to be done to rule out Turner's syndrome, that is 45XO, or if it is 46XX, then it can be ovarian failure, or 46XY where there is gonadal agenesis. The management depends on the cause of amenorrhea. In case of developmental anomalies, the management is mainly reconstructive surgeries. In case of chromosomal anomalies, the gonads are usually removed because of risk of malignancy, and hormone replacement therapy is done. If there is HPO axis defect, like CNS tumors like craniopharyngioma, or if there is hypothalamic or pituitary tumors, these tumors are excised and hormone replacement therapy is done. If the girl has thyroid or adrenal dysfunction, then the appropriate treatment for that is done. Coming to secondary amenorrhea, it is the absence of menstruation for more than equal to 6 months in a woman who was previously having normal menstrual cycles. Any woman that presents with secondary amenorrhea, the first step would be to exclude pregnancy. Next would be to rule out thyroid dysfunctions and prolactinomas. If these are excluded, then we have to go for a progesterone challenge test to see if there is withdrawal bleeding or not. If withdrawal bleeding is present, it suggests that the HPO axis is normal. In that case, we do an FSH, LH assay, ultrasound pelvis, etc. to rule out polycystic ovarian syndrome. If there is no withdrawal bleeding, then an estrogen progesterone challenge test is done. If there is still no bleeding with this test, then it suggests uterine synechiae, and this has to be confirmed with hysteroscopy. If there is bleeding, then we again do FSH, LH levels. If these levels are high, it suggests an ovarian failure. If they are low, then we have to do a GnRH study. If that is positive, then it is hypothalamic dysfunction. If that is negative, then it's pituitary dysfunction. Treatment is again based on the cause of secondary amenorrhea. Treatment, particularly for polycystic ovarian syndrome, would be weight reduction, combined oral contraceptive pills, administration of anti-androgens, management of metabolic syndrome with dietary modification and starting metformin. And if the woman is desirous of pregnancy, then ovulation induction also has to be done. If the cause is prolactinoma, Then initial medical management is done with either bromocriptine or cabergoline. If medical management fails, then surgery is done via transsphenoidal approach. In case of thyroid dysfunction, appropriate management has to be done. If there is ovarian failure, then hormone replacement therapy can be done. And if there is presence of uterine synechia, then adisholysis and iodine